And now I'm going to share my screen, my friends, and then I will become a little bobblehead. And hopefully everyone will be able to see the slides. So let me just get those all the way up. And every once in a while, I'll be entering or allowing people to enter the room, which sometimes causes a little bit of a problem. So today I'm really going to talk, and I'm going to do that pretty quickly because I think everybody here already really has a basic understanding of how to order insulin here at Grady Hospital, which must be administered or deployed through Glucommander. And I always think language is really important. You are putting patients on an insulin drip. Glucommander is the methodology for regulating the rate. We're not putting patients on Glucommander, we're putting patients on insulin. And so that's really what I want to talk about, and talk most particularly about what is our purpose when we're utilizing our Grady-based protocols for either DKA via Glucommander or non-DKA via Glucommander. And I'm just going to remind everybody, when you join Zoom, it doesn't automatically mute you. So please mute yourselves unless you have a question. Thank you. So we think about our number one purpose, and the global overarching purpose is really going to be differentiated by whether or not the patient has DKA or non-DKA. If our patient has DKA, that means, of course, that we're not even necessarily looking at beta-hydroxybutyrate in the blood. What we're basically saying is they have a wide anion gap. So if they have a wide anion gap and they're hyperglycemic, we're going to assume that they have DKA until proven otherwise. Now, our number one purpose with the administration of insulin in the DKA patient is, yes, indeed, of course, we'd like to treat your hyperglycemia if you indeed have hyperglycemia, but more importantly, we want to limit your ketosis. So the way our Grady protocol is written is to assure that your patient always has a carbohydrate store or carbohydrate source in order for you to adjust insulin appropriately to obliterate ketosis. Now, that is embedded in the Grady protocol, but it is very nurse intensive. So really, really important to remember that our focus with DKA is to obliterate ketosis. And we are going to evaluate that by your anion gap. Once the anion gap normalizes, you are no longer in DKA. You might still need insulin, and that's totally fine. But we'll either transition you to a non-DKA drip, or we'll transition to a long-acting sliding scale. Just want to remind everybody on Zoom, you don't automatically mute, so please mute yourself. Our second purpose is, of course, to treat hyperglycemia. And for most DKA patients, that will be treating number one and number two. So really, really important. We are seeing more and more and more patients with the advent of newer agents that patients are using outside of the hospital to manage their diabetes. We are seeing a singular increase, not in DKA or non-DKA, but in euglycemic DKA. So really important for us to appreciate that, because when we're ordering insulin for those patients, we're going to pay particular attention to the obliteration of ketosis and their narrowing of their anion gap. Something that's really important for us to appreciate and understand about Glucommander, which sometimes doesn't seem to be a constant for us when we're talking about utilizing Glucommander to adjust insulin, is that when you order insulin drip on your patients, you will order a multiplier. That multiplier, the initial multiplier, is where we start with rate calculation for insulin based on the patient's blood sugar. We'll start with the multiplier to calculate the rate of insulin. But as time goes on, Glucommander is evaluating algorithmically the patient's response to the increase in insulin, and the multiplier will adjust accordingly. You should never, ever go in and change the multiplier on Glucommander. That is done automatically. We had 2 CTS patients where that occurred, and unfortunately, those patients became hypoglycemic. So one of the biggest issues is for us to really understand and appreciate that the Glucommander algorithm adjusts the insulin rate utilizing a multiplier that is actually continuously reevaluated by the patient's response to insulin, and it's incorporating the BMI, how much the glucose level has dropped over an hour's period of time or over 30 minutes period of time. And that multiplier is adjusted with a very intricate and complicated algorithm to the 5th decimal point. We're going to take a look at that in just a minute. And I also want to remind you, no matter who you're taking care of here at Grady, whether it's a CTS patient, an adult patient, anyone else, our target range at Grady is 140 to 180. We have a CTS profile. Dr. Ward does not want us to use it. She would prefer we never use it. She has asked me if I can remove it from Epic. I have made the request, but it is part of the Glucommander algorithm, so I may not be able to obliterate it, but our target will always be 140 to 180. The only time that won't be true will be if you are working with a laboring mother, at which point we will drop that target. That will be in a particular OB laboring mother order set. You all, I don't think any of you will have that patient, hopefully not, therefore you will never use that. So the multiplier and the target are what really ensure a relatively safe drop in your patient's blood sugar and protecting them from hypoglycemia. So again, the focus of continuous IV insulin management utilizing the Glucommander is the Glucommander is actually going to adjust insulin to help manage the glucose and bring it into an acceptable level, which is the target range. And we are going to pay attention to the anion gap because we, of course, want to obliterate ketones. Everything else is part of the Grady protocol. Fluid resuscitation, glucose management for a DKA patient whenever glucose is less than 250, but the patient is still ketotic, you're going to add in more glucose source. Currently, that would be D5-LR at 150 an hour or D10-LR at 150 an hour, depending on where the patient's blood glucose is. That is about to change in the order set to make it one bag, D10, either at 75 an hour or at 150 an hour. So very, very important to appreciate. That's a Grady protocol. There is no protocol for Glucommander. Glucommander is an algorithm that looks at rate of response to insulin and insulin sensitivity and correlates to tell us how to adjust our insulin. That's all it's doing. It's not thinking, it's not replacing us. And it doesn't tell us about when to give fluids or when to give ions and when to give electrolytes, when to pay attention to metabolic acidosis. Really is about adjustment of insulin and protection from hypoglycemia. Okay, so this is in your DKA Glucommander order set. Now remember, you cannot, even if you have a school of medicine that is telling you, I don't like the Glucommander, I don't want to use the Glucommander, I'm writing orders for patients to go on IV insulin, I'm the attending physician, you will do what I say, which happened last week, and really was a very bullying episode to put a patient on continuous IV insulin without Glucommander. That is against our protocol, and that always has to be kicked to Dr. Robert Jansen. So we don't need to have anyone get into an argument about this. We just are always going to say, this is the way we administer insulin here at Grady. Continuous IV insulin is only via Glucommander. And if you're really struggling with that, or you don't like Glucommander, you don't believe in Glucommander, please take that up with Dr. Robert Jansen. We are not going to be able to put patients on continuous IV insulin outside of Glucommander. We had 2 patients where they had precipitous drops over 300 milligrams in 1 hour, which you and I both know is profoundly dangerous. We don't want that to happen. This is your DKA order set. When you go into your DKA order set, you, of course, look at all this order here for insulin, and our multiplier with DKA is always 0.01. There's no other choice. You cannot choose another multiplier. And our target range, which will now default, you don't even have to think about it, we default the target range now to 140 over 180. But what you do want to pay attention to is this. First of all, we never bolus our patients with insulin once we start Glucommander, never. And you should not start Glucommander if you've just bolused a patient. You need to wait 30 minutes to an hour after an IV bolus before you start on continuous IV insulin via Glucommander, because there's no way to adjust the understanding of insulin rate adjustment via Glucommander when you've given a bolus. We do not bolus patients with insulin. It's actually quite unsafe, so we'd really prefer overall that nobody boluses patients with IV insulin, continuous or not. Okay, sorry. So sorry, sometimes it jumps ahead. So down here, you'll see that the order, the way it's written right now, it's caused some confusion. So I've actually made an application for the order set to change, but every time your blood glucose is less than 250, but greater than 150, you give D5-LR at 150 an hour. If the blood glucose is less than 150, you give D10 at 150 an hour. So that's the way the order set is right now. You are protecting your patient from worsening ketosis by giving them glucose to travel along with the insulin to obliterate their ketosis. It is in the best interest of your patient, the safest methodology, that once you have narrowed the anion gap, you now should transition to long-acting sliding scale, or you should transition to a non-DKA drip. Because what is currently happening is that once we get patients to target blood glucose and we've obliterated ketosis, so their gap is narrow, we're making them hyperglycemic so we can balance that insulin because they don't have glucose stores. Remember, that's one of the biggest problems for a DKA patient is they really don't have much stored glycogen. So we really cause a significant problem, plus a safety issue, plus increasing work for the bedside nurse, which is not necessary. So I really want you to pay attention to the narrowing of the gap. Okay, so the DKA protocol, insulin adjustments recommended order via Glucommander, fluid resuscitations in the Grady protocol, potassium replacements in the Grady protocol, glucose support is embedded in the Grady protocol, and you should stop the DKA protocol. That doesn't mean you can't do continuous IV insulin. All you're doing is terminating the DKA protocol, ordering the non-DKA. The nurse isn't going to do anything different, except they're not going to have to go back and forth between 150 of D5-LR and 150 of D10. Now they're just going to give the patient a continuous carbohydrate source. That would be 40 mLs of D5-LR or D5 normal per hour. Nothing else will change. You're not DCing insulin. You're just transitioning how we're going to treat our patient because they no longer have ketosis. So my advice, what would be the best, the safest, the easiest, the most valid is that when the gap has narrowed, transition to long-acting sub-Q or transition to the non-DKA protocol. Once the patient's on non-DKA, of course, they're going to get D5-LR or D5 normal at 40 an hour. All right, so we're going to take a look at this patient. You can see last blood sugar 159, the gap is 15. This is a patient who was admitted to MICU. I didn't follow them after I captured this morning, but their blood glucose is within target, 140, 180, but the belief was patient has an anion gap. He has a hemoglobin A1C of 15.4. So basically your patient has used up all his storage of glucose. He is in severe ketosis. It's not that profound at this point. I think it was probably worse a little earlier. He was started on an initial multiplier 0.01, and that's the last multiplier that was used. That's adjusted every single time the blood glucose gets adjusted. And here's his target range. So we can appreciate when we look down here at this patient, he's been placed on IV insulin, and the only reason to do that in a euglycemic patient is because they have euglycemic ketosis. So bravo, whoever ordered this. I didn't look up who ordered it. This was from this morning. Very nice work, beautiful job. Very important for you to explain to the bedside nurse. It is vitally important in this patient who has ketosis that insulin and glucose support begin at the same time. Even though it populates in the MAR, it often gets ignored. So I'm asking you all to make sure that your colleagues, your bedside nurses, appreciate, I'm starting this for euglycemic ketosis. We must give the patient glucose in order to support them so the insulin can transport that exogenous glucose into the cell and stop ketosis. Really, really important. Here's another patient who you can see was in 7B for quite a while on insulin. And initially, I'm assuming the patient had a wide anion gap. He's on 36.6 units of insulin, target range 140 to 180. This was the multiplier that was ordered, but over time, you see the patient's been on insulin a long time. Over time, you can see the initial, which was 0.01, is now 0.14568. And this is what's being utilized to calculate his insulin. But over here, you'll also notice that there's something called meal bolus. It's actually meal adjustment. It's a meal adjustment in insulin where we balance the carbohydrate intake of the patient to the adjustment in insulin to mimic endogenous insulin support. This is incredibly important because when you come and make your rounds, you go, oh my God, he's on 36 units of insulin. Well, that's a good thing. The first thing you would do is say, is the IV working? Is it infiltrated? Is this good insulin? Is the patient sneaking food? And if you ask that question, your nurse would say, no, patient is eating. Okay, so when I look at this patient, you can see when he first came in, he has these 2 red balls. That was called meter max. Meter max means anything above, at this time, anything above 600, the point of care meter cannot read. Okay, but all you ever enter into Glucommander, ever, is point of care. You never can put laboratory data in there, and I'm going to show you why, what actually happened to that patient that I mentioned earlier. So you'll see here that perhaps the nurse wasn't happy with the adjustment. Maybe they didn't know better, but it was 600 and 600 with the red dot. That means we told the glucometer it was meter max. And then the nurse actually put in 600, which then told Glucommander to adjust. Glucommander is designed to take 3 greater than 600 meter max readings, not adjust the insulin until number 4. And that's in order to bring behind the scenes to slowly bring the glucose down. Once the glucose goes below meter max, that would be below 600, then you'll start to adjust your insulin very aggressively. And we're going to see that in just a moment with our patient. Oh, maybe we'll see it a little bit later. I'm sorry. I thought it was right there. So sorry. But you can see right here, your patient is pretty well controlled. And then when he eats, we're adjusting the insulin up. And that insulin adjustment upwards is based on the carbohydrate load that we're feeding the patient and the percent of the carbohydrates that the patient is eating. And try to make that as easy as possible. I tell all nurses, initially I defaulted it 30 grams of carbohydrates, and then it's 0, 25, 50, 75, or 100% of the meal eaten. That actually tells Glucommander how to adjust in order to balance the insulin to the increase in carbohydrate. And then the insulin will be adjusted downwards in anticipation of the glucose slowly coming down. So just like your own insulin works, that's how meal adjustment works. Lots of times we have patients like this patient where we want to feed them before we take them off of IV insulin. Your nurse, I train everyone I can, but we turn over a lot. Nurses get trained by others. They might miss some points. It's a lot of information. We have to always tell Glucommander that we're feeding the patient. And we're going to take a look at that a little bit later. The non-DKA protocol always means that your patient is hyperglycemic without ketosis. Okay, that's it. Doesn't mean you've differentiated type 1, type 2. They just don't have ketosis. So the non-DKA protocol is for all hyperglycemia except for the hyperglycemia or euglycemia that presents with ketosis. You cannot, it doesn't matter if their glucose is 1500, you cannot start insulin without a continuous carbohydrate source. So typically what we say is that has to be a continuous source, not just eating. It has to be a continuous source while you're on continuous insulin. So that's D5-LR at 40 an hour, D5 normal at 40 hour, continuous tube feed to target, continuous parenteral feeds to target. Otherwise, if you're on insulin for non-DKA, you must be receiving 40 mLs of D5-LR per hour. That protects your patient from incidental and profound hypoglycemia. That's in your order set right here. This is a hard stop right here. Hard stop. You got to order one or the other. Now, many of you put patients on insulin without ordering that, and then we see what I would tell you is glycemic variability. They drop a lot, and then you have to add something, and they go back up, and they go down and up and down. which is really dangerous. And the design for Glucommander is to keep your patient relatively stable within target, okay? Now, there's a lot of things Glucommander can't adjust for, like steroids, like infiltrated IVs. Glucommander doesn't adjust for that. It's not AI, it's not Big Brother. It is a mathematic algorithmic management tool. Okay, so you can see on this patient, does not, if he has an anion gap, it will always populate here. That'll always populate. Anion gap comes from the lab. Blood glucose is point of care. Anion gap comes from the lab. So if we have a wide gap, yes, if you have a wide gap, if you have a wide gap, it will always populate here and it will continuously update the display until the gap is normal, and then it will just display the normal gap. You don't display the gap if the gap is normal to begin with. Okay, so my patient's last blood sugar, 336, his initial multiplier was the adult multiplier, not the sensitive, 0.01 for renal failure, for diabetic type 1, for elderly patients. Everybody else should get a multiplier of 0.02, and you can see that was what was ordered initially, but the multiplier adjusts over time in order to help us adjust the insulin to get our patients under control. And currently, your patient's at 336, and his insulin is 26.3. So I'd be asking some questions myself. Look, your patient started here, and then he came down into 170, and then he went back up. Okay, so I'm going to ask a couple of questions. Is he eating and we didn't do a meal adjustment? Did we just change the insulin bag, or did we just change the IV? Or, taking a look at where this patient is, so I already know what the problem is, did they get steroids? If they got steroids, or if you bump them way up on their epinephrine, you're going to see glucose go up significantly. And indeed, that is what has happened here. So just taking a look at the patient, he starts at 600. That should have been meter max. Okay, starts at 10.8. The next glucose 553. You can see the insulin is continuously adjusted upwards until we get the patient to have a, not even in target, but have a significant drop since the beginning, right? He started here at 1425 and now at 2025. So 6 hours later, he's now at 271. Our insulin rate drops and he's doing pretty good. Now he's down to 230, then he's down to 170. But by the way, he gets a gram of steroids and now his blood glucose starts to go up, 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 up. If I could actually predict the bioactivity of steroids, I could build, and I've been working with Glytech about this to say, I need us to have, and I'm sure everyone in the world does, a way for Glucommander to adjust insulin based on bioactivity of steroids. Because when we're talking about our neuro patients, they're getting steroids and you see that they have a fair amount of glycemic variation, and we never want them to have hyperglycemia, but also we don't want to allow them to have hypoglycemia. But here, our patient got steroids, and you see that despite the fact that the insulin is going up, 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 your patient's blood glucose is going up, 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 and that's because of his response to steroids. So when you see that high dose of insulin, you should always ask a question. And about 2 months ago, I got called about a patient. They said, we're at 40 units. We've just been going up and up and up. Is he on epi? Is he on steroid? My first question was, does his IV work? And the charge nurse and the nurse director assured me that it did. Not on epi, didn't get steroids, isn't eating, insulin is good. We changed the insulin bag, still way up. And then they realized that indeed the IV had infiltrated. And so now the patient has a massive bolus of subcutaneous insulin. Okay, guys, got to turn off your insulin drip right now because he's going to start absorbing that sub-Q. And indeed he did. And I asked them to check the blood glucose every 30 minutes, talked with the APP. We, when the patient kind of dropped down to about 120, we gave glucose support, started back on the insulin. No worries, was fantastic that bedside nurses were really paying attention to that high level of insulin without causative reason that they could see. Okay, so just remember, Grady protocols give you your multiplier, 0.01 on DKA, target 140, 180, focus on ketones, and keep that blood glucose up until ketones disappear. Non-DKA insulin is initiated with either the initial multiplier 0.01 or 0.02. Remember, that's just where you start. It's not where you're going to stay. That multiplier is going to change in consistency in a consistent manner with the way the patient is responding to insulin. Our target will be 140 to 180, but here we're going to focus on the blood glucose. So sometimes the older recommendations were when you have a really hyperglycemic patient and their blood glucose gets below 180, stop. Don't give any more insulin. You don't need insulin anymore. When their glucose gets below 180, you should be de-seeing the insulin. We're allowing patients to stay on insulin a very long time and having to give them a lot of support to maintain the insulin. We shouldn't be doing that unless we still have ketosis. Otherwise, we should not be doing that. You yourself, APPs, you do not go in there and order nurses to put in a custom multiplier, to just make up a multiplier that you think is going to adjust the patient, or to put in false glucose data. Now, I don't think anybody here has ever done that, but it did just happen recently, and that was under the direction of not only an attending, but actually the chief of service, who ordered the nurse to do something that was outside of what they should have been doing. And despite the fact that they had a lot of discussions to say no, it ended up happening. And it's dangerous. You do not go in and change the multiplier. You do not bolus patients with insulin. If you look at this patient, you'll see here, patient starts at 600, target. Your question would be, and I am so appreciative. I had a fantastically responsive CV-ICU APP, I'm not going to say who it is, who I called about this patient, because when I saw what was happening, first of all, my friends, the patient's multiplier is 0.05. First of all, that's only for CTS patients and only if specifically ordered. That was not ordered for that patient. And the target for this patient was 100 to 140. But the target that was ordered by the provider was 140, 180. So that's a nurse transcription problem. So the nurse actually wrote down, made the multiplier wrong and the target wrong. And you know that because here's how I found out about the patient, because I got called because the insulin rate was so high. They had just started the patient and look at where the insulin rate is. Okay. Well, that's a problem, right? Someone called me and my normal questions are, is your IV working? Are they getting steroids? Are they on, are they sneaking food? But when I looked at it, I said, oh my God, you just started and you're already on 32.9 units for a blood sugar of 587. That's extraordinarily high. This was a dangerous situation. I called the APP. I could have changed things there, but I don't go in and change stuff until I know that's what you want. So I called the APP. She said, no, I ordered 0.01 and a target of 140, 180. So I went in and changed the multiplier down. I went in and changed to 0.01. And I changed the target to 140 to 180. If you look at this, you'll see from 2351. So just to show you on the Glucommander, 2351, the next blood glucose due at 0051, 1251, not really late, about 17 minutes or 16 minutes late, excuse my math. Not much of a drop. That's because the patient was above 600. So we don't really know where they were unless we correlate that. Now they're down to 587. Next blood glucose should be done at 205. Look at your insulin, 32.9. Can you afford to be 1 second late? Next blood glucose due at 205 doesn't get done until 304, 60 minutes late. So, by the way, you've had a very significant drop in your blood glucose, right? You went from 587 to 255. Now, that was over 2 hours, but it's still a significant drop, could lead to hyperosmolar shift, could lead to brain herniation. We can't allow that to happen. Cannot be late. Now, you don't control that. That's the bedside nurse. But you can see it was due at 205, got done at 304. Very significant drop now in the insulin rate. The multiplier is the same, but the patient's blood glucose has responded. So we dropped now from 32 to 12. And then again, because you're asked to do this now because of that significant, because Glucommander sees that it's a significant drop, have to do the next blood glucose at 30 minutes. This is when I called and I said, okay, make sure your nurse knows that she can't be late. And after that 338, I changed the multiplier to 0.01. Actually, I didn't change the 0.01. I calculated what it was going to be and put in a custom multiplier. So it was probably 0.01523 or something like that, and changed the target back to 140 to 180. And when I looked at the chart, I actually saw that the order was 0.01, target 140 to 180. So, sometimes people are in a hurry and they just kind of click. So that was concerning. It didn't go on very long. Thank goodness somebody called me about it because they were worried about how much insulin the patient was getting. And they wanted to know what I thought was wrong. When I looked at it, it was pretty obvious to me. Okay. But what I want you to know is in the upgrade that we had last Tuesday, so you might know Glucommander was down for 9 hours, target and multiplier will self-populate directly towards the Glucommander. Right now, the nurse has to transcribe it, but now it will target and multiplier will self-populate into the initial order set. So now you just need to be careful. And in this case, the provider, this wonderful APP, did a fantastic job, ordered it correctly. It's a new nurse, probably pretty stressed, but still it's a transcription order, and it could have really, really harmed the patient. So I'm also really grateful that people feel that they can reach out to me, and you should feel like you can reach out to me, because sometimes I can just look at it and say, oh, I can see what's wrong. You might be too close to it. You might not know the Glucommander and insulin well enough to really see what was happening, because that multiplier was 5 times what it should have been, and the target was 40 milligrams lower than it should have been, because it was 100 to 140 instead of 140 to 180. And Glucommander is going to adjust that insulin up because it sees that as a CTS patient whose goal is to get, our goal with them is to get their glucose down quickly, just like with a head injury patient. Okay, so I'm going to go back to that patient. I think we already looked at him, but this was another one that I wanted you to see. So you can see this is an extraordinarily beautiful utilization of IV insulin and Glucommander. And by the way, you have to be patient. It's just like renal replacement therapy. You know, it's not like doing IHD where you clear all the fluid and the ions immediately in 2 or 3 hours and the patient gets really sick. This is actually a slower process. Normally it takes 5 to 7 hours to get our patients to target, because we're trying to do it safely, which means we really prefer to drop less than 80 milligrams per hour. We never want to drop more than 100 milligrams per hour. If you've dropped 100 milligrams, Glucommander is going to ask the nurse to measure the blood glucose every 30 minutes, because that's an unsafe drop. It's meant to be a patient safety initiative. So I just wanted to show you on this patient starting at 1856, 436 blood sugar. Here's your initial multiplier, and that changes all through the shift until 6:20 in the morning. And you can see that that is how you got that higher level of insulin, because the insulin multiplier, which basically is like a fudge factor that allows us to calculate the insulin rate appropriately to the patient's BMI, to the patient's response to insulin, and it will adjust more aggressively when it is clear that the patient is insulin resistant, until you break through that insulin resistance. So right now you're here at 20, but now your blood glucose is coming down. And so as the blood glucose comes down, you will actually go downwards on that insulin rate. Once you've broken through the insulin resistance, you're going to need less insulin to manage the patient's blood glucose. Insulin management is very complex, and that's why we're so grateful to Glucommander. Again, just taking a look at this, you can see this is really quite lovely. We get the blood glucose down relatively safely. When you have 4 blood glucoses in a row, so here's the first one. Oh, no, sorry. Here's the first one, 155, so within the target. After the 4th blood glucose in a row, that's inside target, as long as it's between 140 to 180, Glucommander will shift to every 2-hour measurement of blood glucose, which is very beneficial for the nurse. If the nurse can stay on time, manage the patient correctly, that's going to happen more frequently. And then it means we're only doing a blood glucose every 2 hours with an insulin adjustment every 2 hours. And you can see that here. This was really a beautifully managed patient that started with that low multiplier, and the multiplier kept going up and up and up and up. And then we finally get that patient under control. And our insulin rate is down, and then the blood glucose goes up again. And Chavi did a fantastic job. He was really staying right on time with his blood glucose measures. And that really is very, very helpful when we're looking at our patients. Okay, so that's your multiplier. Now, I want to remind you, only point of care can be entered into Glucommander. Now, historically, that required that the nurse pressed a button called meter max. Behind the scenes, you can see your patient's blood glucose was really, really high. and it's trending downwards, but it's doing it safely. But at the Glucommander level, where we were pressing meter max, what would happen then is you would not adjust insulin until every 4th blood glucose if it's still above meter max. As soon as the blood glucose comes below the meter max, you're going to be adjusting more aggressively, because now the point of care data, which is real time and right now, and lab data is old. So we don't use old lab data. We use real time right now data. So you can see right here, you've got meter max, and somebody put in 601, probably just because they didn't know. And then it goes back to meter max. And then somebody says, insulin isn't, someone looks at it, I'm pretty sure, a provider looked at it and said, this isn't adjusting. How come you're on the same insulin rate? That means you don't understand the Glucommander. Okay, Glucommander is only going to adjust every 4th blood glucose when you're above meter max, because we cannot do a real-time right now true evaluation of your blood glucose. That's a limitation of the glucometer. So the nurse was, I'm sure, encouraged, because it was the same nurse, was encouraged to put in the actual lab value, 961. Well, now what we'll see is a plummeting of the blood sugar. And it can be quite rapid, and it can be really dangerous. So I just want to show you that along here, okay? So you can see, first of all, when the nurse puts in 600 or 601, it takes it out of that meter max. But here is correlated to my lab values: 1521, 1467, 1153, 961, 341. So what I'm saying is, if you want to look at lab data to see how well your patient is doing, bravo. But do not put that data into the Glucommander, because you are going to actually trick your Glucommander. So again, shows you this laboratory data and how it's dropping over time on this patient. Okay, so this was an excellent use of meter max. You can see meter max, that's in a red dot. Meter min, which is 10 or less, never ever had it since we started with Glucommander in 2016, never had a meter min, never had anybody whose blood sugar went below 40. And that is really rare, less than 0.01% of the over 9,000 blood glucoses that we have measured. Less than 0.01% were 40 or less. So that is fantastic when you think about all the different areas that we're using. And thank you all very much for the hard work that you're doing. Okay, so you can see here that your multiplier doesn't adjust, and it adjusts on the 4th glucose. So it went up, and it only went up mildly from 5.4 to 6.8. But then you have 2 more meter max, and now your patient comes just below meter max, 596. You're going to adjust up, and you're going to adjust up, and you're going to adjust up, and you're going to adjust up. And you can see you adjust up until you break through that insulin resistance to 20.4. And now your insulin rate starts to come down. Your multiplier starts to stay more consistent, doesn't come down, because we're still having some trouble organizing our patient, but we're seeing the insulin adjustment goes down from 20.4, and we have a little bit of variation there. Okay, I think probably all the same thing. Just wanted to bring to your attention this patient, who was a medical ICU patient boarding in the ED. The medical attending said to the nurse, I don't believe Glucommander. I don't like it. I want you to just put the patient on 10 units of insulin. And the nurse said, we don't give insulin IV continuously without Glucommander. And the attending said, well, I'm the attending. You need to do what I say. I'm in charge. I'm the chief. I want you to do this. You have to do it. Really, she felt pretty bullied, and I don't know how it happened, but the patient did get on insulin. Then the patient got admitted. Patient was admitted already, but then got transferred over to the critical care area in the emergency department, and a MICU nurse was taking care of the patient. She said, I'm not doing insulin without Glucommander. I'm not going to do it. And so they gave in, put the patient on Glucommander. But then you'll see down at the very bottom here that this was when the patient got put on Glucommander at 0201, 600 milligrams per deciliter of glucose, with that nice low multiplier, 5.4 units. Doc didn't like that and said, I want you to put in 1200. And the nurse put in 1200. It's only 8 minutes later, put in 1200. And that adjusted the insulin up. Okay. And that really tricked Glucommander. But you can see here that your patient had, based on the lab data and the real data, the point of care data, look like a really profound and significant drop in the patient's blood glucose. Okay, so really important to see what this was like 2 or 3 days ago. Nurses can no longer put lab data in. You are topped at 599. If you put in 605, if you put in 800, if you put in 900, you put in 2000, it's going to populate 599. It's forced meter max because this is such a significant safety issue. It's a forced meter max. So I want to make sure you all appreciate that, because as long as your patient's at 599 or above, insulin will not get adjusted till every third blood glucose. You want to check on the progress of Glucommander, do a lab value, do comparative lab values, but they cannot be put into the Glucommander. The Glucommander is going to adjust slowly. And you can see that this is a nice, safe adjustment, getting our patient down towards their target. Okay, this was also, of course, a patient with DKA. Okay, just tell me it's time. Yes. So now you cannot put in blood glucose greater than 599. Just remember the anion gap. It will show you when the gap is wide and when the gap is normal. Here's a gap that's wide. Remember, you've got to, on this patient, they did not hang D5-LR at 150 or D10 at 150. So the patient dropped their blood sugar. So just make sure folks are given that, glucose. Also remember that when patients become hypoglycemic, they will be told how much D50 to give to the patient. That D50 amount is calculated to get the patient's blood glucose above 80, typically to mid-range, but usually it's just above 80, at which point you will start back on insulin at a very low dose to prevent the smoky effect. So very special scenarios that we always want to think about when you can't get blood glucose under control. Check the IV, check the lab, just see what's happening. Check that the insulin is appropriate and make sure that the patient's not sneaking snacks or eating, because your insulin will be requested to be adjusted upwards to match that carbohydrate load. But as soon as those carbohydrates disappear, your patient can become hypoglycemic. If your patient is going off the unit for a test, to the MRI, to CT, or something else, you need to pause insulin and carbohydrate sourcing, because we can't actually manage the patient outside of a Glucommander accepted area. That is all the ICUs. It is the step-down areas, PACU, OR, ECC. So thank you for your attention. I'm sorry I went a few minutes over. Thank you very, very much. I'm happy to answer any questions, but I also would love to set you free. I hope this was meaningful and helped you to understand more deeply why we use Glucommander and how to use it. I am now going to stop my recording and say thank you, but I'm available for any questions. Thank you.